to treating obesity. I'm Sandra Leah. I'm the Vice Chair for Obesity Canada in the Toronto chapter. I am also a patient advocate who has lived with obesity in the past, and I work in the area of food addiction. Today's topic is obesity a disease of the brain? And I thank you for answering the poll, and we'll review that poll at the end. Allow me now to introduce Dr. Arya Sharma, Professor of Medicine at the University of Alberta and Scientific Director of Obesity Canada. Over to you, Doctor.
Thanks, Sandra. So as all of you know, Obesity Canada is Canada's national registered charity dedicated to improving the lives of Canadians living with obesity. We do this through obesity research, through education and advocacy. Through its work, Obesity Canada has educated health professionals, it supports researchers, it mentors trainees and students, and really works with policymakers to ensure that all Canadians living with obesity receive the same level of prevention and care as Canadians living with other chronic diseases like diabetes or hypertension. To this effect, Obesity Canada has been working with partners to recently release the clinical practice guidelines for the management of obesity in adults. And we will be discussing some aspects of these guidelines today, as well as other issues with our today's panelists. So with that, I'd like to welcome today's panelists, and I'd like to start with you, Sandy Van. Just tell us a little bit about yourself and your practice and what you do, what got you into obesity and what it is that you do in your practice.
Hi, thank you for the intro, Arya. My name is Dr. Sandy Van. I am an obesity physician. I have a background training in family medicine, but I specifically honed my practice to obesity medicine primarily because I thought that in residency we weren't addressing a lot of the things that I felt were being presented in family medicine. I offer cognitive behavioral therapy, which is a form of psychotherapy, along with medical management to help patients address their weight struggle. My practice is located in downtown Toronto.
Thanks, Sandy. And over to you, David. If you tell us a little bit about your practice and your interest in obesity.
Sure, Arya, thank you. And thank you for inviting me. Thank you to Obesity Canada for inviting me. I'm David Macklin. I'm a family doc. For 17 years, I've worked exclusively in the area of weight management. I run a couple of comprehensive weight management programs, one in downtown Toronto, one at the Toronto Mount Sinai Hospital. I'm a proud co-author of our recently published national treatment guidelines for the treatment of obesity in Canada. And some of the principles that we will be putting forward in those guidelines, I'll even get a chance to talk about today. I'm very excited to be here, and thanks again for inviting me.
All right, so let me start with you, David, right away, and let's look at today's topic. Is obesity a disease of the brain? So if you had to explain this in very simple terms, why would you even think that? I mean, what does the brain have to do with appetite regulation, energy regulation, decision making, all of that? Just share your views about that and explain to us why this should be considered a disease of the brain, or perhaps not.
Thanks, Arya. I do consider obesity to be a disease of the brain. What many people don't realize is that, or we can well describe obesity as a primarily genetically conferred. 70% of the risk of struggling with weight in one's lifetime is conferred genetically. What many people don't realize is that the great majority of those genes are expressed in the central nervous system. We have a brain that was built for a time when calories were scarce or could be scarce. And that brain has collided with an environment that is filled with ultra-processed food and ultra-portioned food and ultra-available food. And that collision in those who are genetically vulnerable can be described as the underlying pathophysiology of the condition of obesity. The brain has 3 levels to its appetite system. The appetite system will, for example, be extremely complicit in defending against fat loss. So one of the functions of the brain is, and it's in the hypothalamus, or in what is called the homeostatic system, the lowest part, the oldest part of our brain that we share with mice and rats and even flies to some degree. This part of the brain is exquisitely sensitive to recognizing fat loss through dropping levels of leptin. And in response to that, it will speak to the next 2 levels of the brain, activate more motivation to eat. The drive to eat will grow, and many people will therefore, after weight loss, be at risk of weight regain. That's one example of how the brain regulates appetite.
So you said that there were 3 systems. So what is the second system and what's the third system? Just briefly, we'll get back to that again, but just so, because you said there's 3, we've talked about the homeostatic system. What's the other 2?
The center system, so the second system, goes by a number of names. It could be the motivational system, it could be the hedonic system, it could be the reward system, it could be the mesolimbic system. Goes by all those names, depends if you're talking to a psychologist or a neuroscientist. And this is the central part of the appetite system. If you think about it, our brain, if you wanted to summarize what it does, is it motivates us. And of course, the former environment, this was necessary. It motivates us, drives us towards calorie consumption. So this middle layer, the motivational system, is exquisitely sensitive to external cues. It goes through a learning process. What cues in our environment have been paired with tasty food, a learning takes place, and eventually this brain drives wanting, desire, impulse, urge, and the primary biological drive to food. The third level is called our executive system. There's two parts to our executive system, one that thinks very slowly, one that thinks fast. The slow thinking part is usually asleep. It's the part that would make decisions aligned with our values, but the slow thinking executive system usually asleep, and instead an autopilot part of our executive system makes most of the decisions around food, justifications and rationalizations and cognitive bias. In fact, that's a key part of behavioral interventions, is waking up the sleepy part of our executive system so we can think more about our future, and recognizing all the underlying processes that put us at risk of overeating.
So which brings us to the behavioral influence. I mean, you've described a very complex system that is very hard to control. But one of our principal approaches, of course, is behavioral management of obesity. Try to get people's behaviors to change in terms of their eating, in terms of their activity, in terms of everything else. And so over to you, Sandy. You said in your introduction that one of the techniques you use is cognitive behavioral therapy, but there's also other techniques that you use. Can you just take us through this very briefly? Like, what are the if you want, psychological approaches to trying to help people change their behaviors, and which ones do you use, and which ones do you find most helpful?
Yeah, so the clinical practice guidelines highlighted very nicely the empirical evidence to support cognitive behavioral therapy in weight loss. And for those who don't know what CBT is, that's what I'll refer to it moving forward. It's a form of psychotherapy that helps address the underlying thinking patterns that leads one to engage in unhelpful behaviors like overeating or sedentariness, or things that are really misaligned with how one wants to conduct themselves within their health domain of their life. And so typically, in a nutshell, we ask patients to identify what thoughts they're having leading up to specific behaviors that they want to work on, to jot those thoughts down and try to restructure that thinking in a way that enables them to engage in behavior that will help them sustain this behavior long term. So it not only helps change behavior, it also helps to build intrinsic motivation. And as a practitioner, my role is really to repeatedly use the same technique over and over again in my subsequent visits with the patients to enable them to really foster that learning of that approach, so that they can use it on their own and become autonomous with it, essentially.
So, and maybe this is a question for you, David, again. Now, we're talking about changing behavior, but as you made clear, there is also a strong biology here, which is determined by the brain, if you want, by the homeostatic centers of the brain. So now, obviously, my understanding is that these cognitive approaches are not really changing the underlying biology. So sometimes patients are going to need more than just talk therapy, if you want, to actually get control of, especially if they're trying to lose weight and keep the weight off, then obviously they're going to need more. So David, can you take us through what those additional steps are, or the additional pillars of obesity management are, once we've actually, done the psychological stuff? What else do we have, and why is that important?
Sure, thanks, Arya. So the fundamental 3 levels of treatment, or pillars of treatment in obesity management, are behavioral interventions, really plus or minus the adjunct of medication, and plus or minus the adjunct of surgery. And so the reason why surgery exists and the reason why medication exists is going back to what I had previously said. The brain, for example, will fight. It will recognize fat loss, and it will initiate forces of further appetite and decreased metabolic rate to try and defend our former weight. If our ancestors lost weight, it wasn't to look good in a wedding. It was because the food environment was challenged. And so this circuitry makes sense for that former environment. And so the parts of our brain that recognize fat loss and drive appetite up, you and I, all of us, don't have access to. And that's the role of both medication and surgery, because both of those will affect the lower levels of the system. Sandy and I, and hopefully more and more people in this call, will from the top down support through the behavioral interventions. So that's the top down piece. And then the bottom up piece will be both medication and surgery. And if we bring them all together, that's our most effective outcomes.
So when I listen to you, it kind of reminds me of the approaches we used to take for mental health conditions. So, I remember that when I was in medical school, when we talked about someone having depression, psychotherapy was actually a big thing. So the talk therapy, that you could take someone who has depression and you sit down with them, and then in a series of, basically conversations, you can talk them out of their depression. But that completely changed once we recognized that, well, depression is more than, just being sad, that there's actually a chemical imbalance, if you want, between certain neurotransmitters. And that's when we came into the pharmacotherapy for, the use of antidepressants today for treating depression, is something all of us do in our practice. Which brings me to the question, and Sandy, you might be able to answer this one, is what is the role of, medications like antidepressants or even anxiolytic medications for someone who has obesity? Because we do know that there is an association, at least in some people, between depression and obesity, or anxiety and obesity, or perhaps even attention deficit disorder and obesity. Yes. So where do these medications for these conditions actually fit into obesity management? Is there a role? Does it help people lose weight, or isn't there a role? Can you just take us through that?
Yeah. Yeah, that's a great question. I think a lot of people have that in their mind. The thing about, first of all, there's no antidepressants that are indicated specifically for obesity at this time. We know that Health Canada has approved 3 medications for weight loss specifically. One of those medications is a combination of bupropion and naltrexone. So bupropion is an antidepressant within that medication. So on its own, it is not indicated for weight loss, but together with naltrexone under the trade name Contrave, it is indicated. And going back to your question of can we use antidepressants to treat weight? Well, in my own practice, I typically screen for mental health conditions because we know that they're so highly comorbid with obesity, like you said, Arya. And if we do see any underlying active episodes or anxiety, then that's your concern, in my opinion, in my clinical opinion, that you should be addressing the mental health component before you address the obesity. Or there are some practitioners who would say you address them together. And so to answer your question, oftentimes when I see somebody with rampant anxiety, for instance, if we treat that with a medication that helps with that anxiety, oftentimes you can get them to start engaging with CBT for weight management and helping them with behavior changes in that sense. But trying to go for CBT while somebody has a background of high anxiety can be kind of difficult in terms of weight management. So it's really individualized to the patient. I hope that I hope that answers your question.
Okay, so let me ask you, David, perhaps. Sandy has just told us about Contrave, which is a combination of bupropion and naltrexone, and obviously those are 2 medications that both work on the brain. So that makes a lot of sense based on what we were discussing. What about the other 2 medications that we have in Canada for obesity? Do they also, both of them, work on the brain, or how do they work?
Orlistat is in Canada available, and probably in many of the countries, if we have visitors from other countries, Orlistat's been available on the market for some time, but it's a peripheral acting medication. It can be effective. The other medication that is on market for weight loss in Canada is called liraglutide or 3.0 milligrams, or branded as Saxenda, which most certainly works on the central nervous system. The molecule itself is an analog of the GLP-1 hormone. We all make GLP-1, maybe some less than others. And so this analog, in the case of liraglutide, it's 96% identical to the GLP-1 molecule we make ourselves. It lands in the hypothalamus and creates a sense of a loss of interest in food, either a fullness or a loss of interest in food, and acts even more centrally than just the bottom or hypothalamus. It actually acts even in the higher levels of the brain, affecting a reduction in things like wanting.
So if I'm hearing this correctly, the role of medication is really to support behavior change. And you can either do this, in the case of Contrave and Saxenda, you're doing this by directly influencing the brain, In the case of orlistat, you're doing this perhaps through some of the unpleasant side effects that people experience when they, and so it kind of, if you're on orlistat, you have to change your behavior, otherwise, you just can't tolerate the medication. Having said that, I mean, Sandy, this is a question to you. When we talk about people wanting to change their behaviors or needing to change their behaviors, we know that almost everybody living with obesity has already tried doing this, and they haven't often had success. And one of the chapters in the guidelines actually deals with bias and internalized weight bias. And so how often does it happen to you in your practice that when you're trying to talk about behavior change to one of your patients, you find that they're not really receptive? And how do you deal with a patient who's not receptive to talking about obesity, and perhaps are just looking, are not receptive to talking about behavior change, are perhaps just looking for a quick fix? They said, I've tried behavior, now I need a medication, or I just want to have bariatric surgery because nothing else works. How do you address that with your patients?
Oh yeah, that's a very common problem. I love that we have medical options for treatment. And I do often get patients coming into me, not for the CBT component, but because they want medication. And I will never deny that. I will never deny somebody medication, because what we want to do is we want to actually treat obesity as a real medical condition. And as a practitioner, we would typically offer medical options if they were available. With regard to trying to motivate behavior change in somebody who has tried time and time again with many failed diet attempts, we know that those failed diet attempts were not because of a lack of willpower. They were actually because the dietary intervention failed the patient, right? So I often explain it to them as, you just didn't have the underlying biology perhaps managed appropriately. And what we find is that if they come in with no motivation to engage in behavior change, sometimes oftentimes when you add that medical intervention, for instance, if you add Contrave on board and they have borderline characteristics of depression or anhedonia, lack of motivation, and increased cravings, you get that tap into the executive functioning because of the bupropion. You also have that reward center that is managed from a cravings perspective, and their ability to change their behavior is heightened. And they then start building that intrinsic motivation to continue with that behavior change because the underlying biological component is now being managed.
Okay, so
there's something from the get-go.
Okay, all right. So now I just want to, take a side question here to Sandra, because Sandra, I want to bring you in not as the moderator, but as someone who's actually lived with obesity pretty much most of your life. So when you hear this discussion about behavior and medication and perhaps surgery and all of these things together, as someone who's been living with obesity, where do you think someone like Sandy or someone like David can actually be of help, in helping you better manage your obesity, if you want?
Yeah, I think that it is important to develop some sort of rapport and trust with the person living with obesity before medication and surgery is advised. So I know for myself, I want to be sure that my healthcare provider understands my unique story, understands how I got to this place, understands what my unique challenges are, so that I can begin to trust that the doctor is there for my best interest, that what they're recommending will be helpful. And because often what I hear is that sometimes the medicine is offered first, and if I haven't built the trust and rapport, I may not be as open to it. And I really like the idea that Dr. Van provided, which is using the medicine as a way to tap into behavioral change and beginning to build some confidence and momentum towards being able to control eating behaviors.
So Sandra, I want to stay with you for a minute, and I want to take you out of the patient role here, because I know that you're actually also you're also a consultant for food addiction. And when you hear the term addiction, obviously right away you're thinking brain. So tell us a little bit about the food addiction. And my understanding is not everybody living with obesity has food addiction.
Correct.
And how do you make that distinction? And what is the role of medication in food, when it comes to food addiction? Is there a role for medical treatment there?
Such a good question. So I identify as a food addict, and the best way that I can describe it is I use food in a way that somebody who's living with alcoholism uses alcohol. So there are many people out there that can enjoy alcohol reasonably and it doesn't affect their life. But for some people, Drinking alcohol leads them down a path where it starts to affect their relationships, their health, their work. And that was the case with my eating. That when I ate certain foods, not all foods, very rarely do we find somebody who's addicted to, grilled salmon and broccoli. When I ate certain foods, it sort of set me up to want more and more and more and not being satisfied. And it started to affect every single area of my life. And so when you're dealing with cravings that are overwhelming, cravings that you feel you cannot get a handle on, and that starts to chip away at your self-worth and your self-confidence, the way that drugs can help with that is to give you just some space. And it'll allow you just a little step up, similar to antidepressants, right? Just give you that little bit more perspective, that step up to be able to implement your health aspirations in a more confident way.
So Sandy, let me ask you, what Sandra has just explained to us is sort of the typical picture of if you want, the food addict or the food addiction. Now we know that there's various forms of that. For example, we have a full range starting from just emotional eating, using food as a coping strategy. Then we have binge eating disorder, which is often associated with past trauma, all the way to food addiction. So when you make that difference, when you differentiate between those different levels, at what point do you think it's important for practitioners to differentiate all these different ranges of psychological behaviors, if you so will? And again, what's your approach to this? Or what would you recommend the approach for this, both on the diagnostic side and perhaps the management side, for people who may not have access or who work in settings where they don't have access to a psychotherapist or a clinical psychologist? So what can you, as a family doctor, recognizing your limitations of time and skill and experience and all of that, what kind of support can you still give or should be able to give as a family doctor to to someone like Sandra or someone who just has emotional eating?
Right. So I heard a couple of questions there. I heard the first question you asked was, when is it important to make the diagnosis, right? So we know that there's a spectrum of overeating behavior, and there's a beautiful paper that outlines this as, or creates an umbrella term for this as loss of control eating. And as a clinician, it would be important for us to differentiate between just loss eating versus binge eating disorder, because binge eating disorder actually falls under a certain set of criteria for different management. There's medication for binge eating disorder. There's another psychological approach to binge eating disorder. And sorry, I'm just going to ask that everybody like share a little background noise.
Yep. Please, can everybody who's not speaking turn off your microphones, because we're getting a lot of noise, background noise.
Yeah, it was a little.
All right, Sandy, go ahead.
And for binge eating disorder, to simply put, there's another management approach. So I think that it would be really important in an obesity consult for a family doc to make sure that the patient isn't meeting criteria for binge eating disorder, because we know there's Vyvanse and then there's other approaches for that. When it comes to loss of control eating, my management is typically cognitive behavioral therapy and obesity treatment if the patient qualifies. And for those who are, your second question was, what do we do as a family doc if we don't have, a referral or obesity management? Is that correct? Was that your second question, Arya?
Yes.
Okay. Well, what I've found to be helpful is assigning bibliotherapy. So having the patient empower themselves with cognitive behavioral therapy that they can work on at home, having them use the family doctor as a checkpoint. So making sure that the family doctor is following up with the patient in terms of the lifestyle management and goals that the patient has outlined for themselves. Also asking patients about the cognitive patterns that they're having that are leading them to overeating. So what is it that you're thinking at night, for instance, when you're about to sit in front of the TV, when the curtains are drawn, when it's 8 p.m., and what is it that you're thinking that's leading you to go to the pantry and search for food when you've just had dinner, right? So helping them dissect that thinking and challenging that. And for family doctors and communities that might have groups, for instance. So Sandra and I have just group because we saw that there was little access for patients who wanted to address their overeating behaviors. If there is, you look into the groups, group therapy has been very effective for my patient population as an adjunct to individual therapy, but it might be also effective for somebody who doesn't have very much access to psychological support in general.
Okay, and perhaps a question to you, David, because I know you also use techniques like cognitive behavioral therapy, et cetera, in your practice. Uh, I'm assuming you didn't learn much about that in medical school. So where did you pick
Correct.
up your skills, and where would you advise that family doctors or other health professionals who want to move into this area as part of their practice would actually get their information? How do you get those competencies of being able to use some of these techniques on your patients?
Right, such a good question. Thank you, Arya. So my undergrad degree was in psychology and neuroscience, and my work within medical residency was on behavior change and smoking cessation. And in 2002, I realized that as the smoking epidemic seemed to be better controlled, that the obesity epidemic seemed to be going in the opposite direction. And so I committed my career to behavior change and bringing all the science of psychology and neuroscience of behavior change to obesity. It's interesting, when I started my clinical practice, I'm not sure if everyone is familiar with the clinical trial called the Diabetes Prevention Program. Diabetes Prevention Program was this amazing lifestyle intervention, which was a modular approach using cognitive behavioral therapy and other behavioral principles that was successful in showing sustained weight loss in individuals and health benefits. And so actually online they had all the PDFs. And so I downloaded them all and actually just started conducting. I hired a dietitian and I started conducting a little diabetes prevention program here in Ontario, Canada, billing the government. I was fortunate that the billing system allowed me to do that. So now all these years later, there's been advancements in behavioral therapy, and I've tried to stay on top of them. Where someone can build unfortunately, the answer to your second question is there are not many resources where individuals who are today maybe even listening in can gain expert and focused education in the behavioral principles of obesity management. Unfortunately, when we look, for example, at the formal educational material, even within the ABOM course there, Sandy and I found this out about a year and a half ago when we went down there to talk. There's unfortunately very little still kind of actionable teaching that's going on in the behavioral field. And so I'm going to suggest that the chapter that we've written in the Canadian Clinical Practice Guidelines is a very good review of the science. And to stay tuned, we're going to be, myself and the other co-authors of the chapter will be providing what we're calling knowledge translation tools, where these tools will take the theory and provide a kind of simple, straightforward tools that a clinician can use within their clinical practice to conduct behavioral interventions.
Okay, so David, and I understand that some of those tools and some of those resources are going to be made available through Obesity Canada, which brings me perhaps to my final question. Where do you see a role for an organization like Obesity Canada in doing the kind of work that you're involved in, and how has Obesity Canada been able to support the work that you're doing and your practice?
So Obesity Canada is a remarkable organization. If anyone's not familiar with Obesity Canada, it's a national organization that was founded, I guess, 17 or 18 years ago, if I'm correct, by Arya Sharma, who's now the current scientific director of Obesity Canada. And this is really a network of clinicians on the one hand who have interest in the prevention and treatment of obesity, and another accumulation, which is a modern iteration of Obesity Canada, of individuals living with obesity, and the ability for individuals living with obesity to have a network and a forum to be able to share their experiences and learn more about what's available for them. So that combination has, through conferences that are held every 2 years and tons of materials that are growing on the very kind of friendly user interface on the website, will become more and more a resource for individuals. If you have questions of where can I find a physician in Canada who is interested in supporting me and might be able to support and treat me, what materials and what types of meetings and what types of events are going to be held in the near future that I could also become part of, not unlike the one that we're involved in today.
And Sandy, what would you have to say, is the role of an organization like Obesity Canada in your practice and your professional development?
I'm sorry, I didn't catch the last 5 seconds of what you had asked.
Oh, I was just asking, so where do you see the role for Obesity Canada in your own professional development?
Oh, Obesity Canada, the website is fantastic. You know, I've in my own patient population, one of the most common um, things that I find is most difficult is helping patients address the weight bias, right? And I often refer them to the Obesity Canada website to help them understand obesity as a disease. As practitioners, we are limited in our time within the clinical encounters, and I find it to be a very useful tool to refer patients to as a resource for the simple articulation of how obesity is a disease, how overeating is a symptom of an underlying biological. And so I think that that's the most use I've gotten out of it. Also, doing educational events, I love referring to it as a touch point for clinicians to use as ways to find access to other obesity doctors in their area.
Okay, excellent. So with that, I'd like to open the floor to questions. And so I'll give back to Sandra now, who's been monitoring the chat boxes, and I can see that there's a lot of questions that have come in here. So Sandra, why don't you let's open the floor. Let's see if there's anybody who wants to ask a question live, because we do give preference to people who are brave enough to go on camera and ask their question in person.
Definitely. So a couple of ways that you can ask a question. You can virtually raise your hand, and you do that by hitting the participant button, which is lower middle screen, finding your name and hitting the button that says more, and raise your hand virtually, or just turn on your camera and raise your hand the old-fashioned way. And please introduce yourself, let us know where you're tuning in from, and ask your question. So the floor is open. I'm gonna just scan now for any virtual hands that have gone up. But otherwise, I'm gonna ask Rachel to read the first question in the chat box.
Okay, we do have questions. I saw Michael raise his hand there. Michael.
Did I miss it? Michael,
yep.
Unmute yourself and ask your question.
Hi. Thank you very much for putting this together, to Obesity Canada and to Arya, of course, and then the panelists. Excellent conversation. My question is about how do you actually empower patients and therapists and physicians beyond what is on the website right now as a resource? And what I mean by that is I'm running a digital health technology accelerator in Vancouver. And what we know in terms of innovation is how do we actually empower the patients, the consumers, physicians, the therapists, everybody involved in making sure that obesity is kind of a thing of the past eventually in Canada. So are there any plans for Obesity Canada and the clinicians involved to actually look at software as a therapy, or what's called digital therapeutics, which is exploding in the United States, not so much in Canada? So that is my question.
Okay, so Bob, let me address the first part of that question. There is actually, with the launch of the guidelines, Obesity Canada has also launched 2 platforms, one for patients, which is called OC Connect, and your patients can access this through the Obesity Canada website. There's also a second platform called OC Connect Pro, which is for professionals to network and connect each other. And again, you will find the links on the Obesity Canada website. But I do take your question about the use of technology, perhaps in obesity management, if I can summarize it as that. And there is a whole chapter on this issue in the guidelines. But perhaps, David, you could just quickly address, where do you see a role for technology and those apps, if you want, to support patients living with obesity?
Thanks, Michael, and thanks, Arya. So I would take one step backwards before addressing the specific role of technology in obesity management, because just as a reminder to all the listeners, we are, and this is a primary point of our clinical practice guidelines, we are communicating that obesity is a real medical condition, primarily genetically conferred, environmentally influenced, progressive, centered in the brain. And so the most common answer, if we struck out obesity and put asthma, if we put ulcerative colitis, if we put multiple sclerosis, if we put hypertension, just a reminder, the approach to supporting individuals who are living with these conditions is to establish clinicians who, and a healthcare system that recognizes, respects, and offers ethical and evidence-based effective treatment for that condition. So that's really the starting point of this conversation. And so just because we're in a state where we don't have on the corner, for those living with diabetes, in the street corner, we don't have a mom and pop shop who are offering blood sugar clinics where we'll lower your blood sugar, guaranteed to bring you into the 5 to 6 range, and here, spend $2,000 and you can come see us. We have actually a very well-established and effective approach in Canada to dealing with that medical condition. And so my first answer will always be that we have to move as a medical system to recognize this as a real condition and to train clinicians to effectively treat. One point that we always use as describing this as a real condition, I always go on to say, not only is this a real condition, but effective, ethical treatment exists for this condition. And so we don't have to go anywhere further than knowing it's a real condition, treatment exists, but going to the next step then in empowering clinicians with the knowledge, with the confidence, with the competence to provide what we already know is effective treatment for those living with obesity. From a technology perspective, I have no doubt that technology, because of the difficulties of scaling myself and Sandy, Sandy and I are working away and seeing as many patients as we can. And so CBT is effective and behavioral therapy is effective, but currently we don't have enough behavioral therapists in obesity to treat our population. Surgery is effective. We don't have enough surgeons or ORs. Medication can be effective as well, but it's meant to be within a clinical scenario where physicians are supporting patients. And so the place for technology will, in my mind, the place for technology will be likely the ability to scale what are the effective principles of treatment to more and more individuals. And so I really look forward to a time, because everyone has one of these in their hand, when there becomes a marriage of this technology and the principles that we know are effective. Someone needs to put together more expertly, and I can tell you it hasn't happened. Review our guidelines review. It hasn't happened that someone has effectively married the fundamental principles of effective treatment with this yet. So stay tuned.
All right, Sandra, back to you.
Yes, Carmen has raised hand. So Carmen, you can unmute yourself.
Hi.
Please introduce yourself and let us know where you're coming in from.
Tijuana, Mexico. I'm a bariatric physician. I just wanted to know if David and Sandy or Arya, have you had any experience with, actually I have two questions, with yoga or any other type of mindful practices for stress reduction as combining therapy with medication and all of these other therapies for behavior change? That's one. And my second question is, what is your experience in also medication for attention deficit disorder?
Okay, great questions. Thank you, Carmen. So perhaps Sandy, to you, let's talk about mindfulness and mindfulness exercises and things people can do, which of course includes yoga and breathing exercise and everything else you can think of. So just take us, quickly through, what that spectrum of treatments could be and why they're important.
Thanks for the question, Carmen. There isn't much evidence to support yoga or just mindfulness as a whole. There's not enough to substantiate that for weight loss per se. But with that being said, I would never not recommend it. We know that stress is one of the largest modulators of obesity. If we can mitigate stress in a person's life, it often translates into better eating behavior and a higher desire to engage in movement. And so I always ask the patient what it is that they want to do for stress reduction and to do it, right? So if that's yoga, if it's Pilates, if it's running, it differs between everybody. There's not one specific thing that I would recommend. It's whatever the patient finds to be enjoyable and that they can sustain. The second question was, I forget what the second question was, Carmen.
That's for attention deficit
ADHD?
disorder.
Oh,
Yeah.
ADHD.
Yeah.
Right. So sort of under the same paradigm of, well, actually not really. ADHD we know is highly comorbid with obesity. We don't typically, there's no ADHD medication that is indicated for obesity management, but it's up to the clinician, right? So if the patient is presenting with active ADHD symptoms, and they've had an assessment. And in Canada, we know that there's a very comprehensive assessment to determine ADHD. Family doctors can also formally diagnose it. That oftentimes they get treated for ADHD to see whether that impacts their eating behavior. What I see in my own practice is that I have to treat both at once.
Okay. All right, back to you, Sandra.
Yes, we have another raised hand, and it's Catherine Sample. Do you want to unmute yourself, introduce yourself, let us know where you're coming in from?
Yes, hello. My name is Kate Sample. I'm an OBGYN in Wisconsin. And I was curious, Dr. Van, you mentioned that you often give people reading assignments for CBT. I was curious what those are.
Yeah, ideally, I would have my own reading. I know Dr. Macklin in his clinic, he has accumulated a number of resources that he actually assigns, that he's written himself. So when I refer patients to bibliotherapy, I often refer them to Judith Beck's book, The Beck Diet Trap Solution. Judith Beck is the daughter of the founder of CBT, Aaron Beck. And I often get them to read through the Beck Diet Trap Solution to identify any psychological traps, that's what they call them, or distortions, and help them. And oftentimes they come back and say, I really related to the book, and these are the traps that I fall into, so help me with these. And those are typically the permission thoughts. For instance, I've exercised today, therefore I get to eat, or I'm at a social and this person's pushing food on me, I should go for it. So I typically recommend that book for them.
Judith has a copy on her desk that she put up to the screen if everyone wants to take.
Oh, there we go.
Oh.
Thanks, Judith.
All right.
Clearly, she is recommending that book as well.
Okay, Sandra, let's go to the next question.
I'm scanning. I don't see any hands up. Oh, Stephen. Yes, go ahead, Stephen.
Hello, everyone. My name is Stephen from Malaysia, a family doctor. So my question is towards David and also Sandy. And obesity as a disease. So we as family doctors, what do you envision it will be when we are treating it as a disease in the future?
October 7th.
Yeah. So because from my perception, it will be like, okay, you have diabetes, we'll start metformin. Will it be like that in obesity? What will be your comment in another few years' time? How we going to treat it as a disease? Thank you.
Okay, just to paraphrase Stephen's question, I think what he's, the way I understand it is that, I remember the days when in type 2 diabetes, you would spend a lot of time trying to get people with type 2 diabetes to change their behaviors. And then if that didn't work after maybe 6 months or a year, of not being able to do this with diet and exercise, you would perhaps bring up the discussion of medication, and then you would start the medication. Today, of course, is very different. I mean, today, most people, when they get the diagnosis, they pretty much leave with a prescription. In addition to everything else. Do you think that in obesity management, we are going to see a much more combined use of all of the different therapy options that we have? And how is it in your practice, David? How long does it take before you actually, prescribe psychotherapy or CBT or a medication, or perhaps even refer someone to surgery? How long does it take today generally?
Thanks, Arya, and thanks, Stephen. Great question. I'm going to go to answer your question, Stephen, at the starting point. One of the instructions I received from today in today's talk is to leave clinicians with something that they could start using tomorrow. And I know you asked about the future, but I'm going to talk a little bit about tomorrow. Maybe you have patients lined up. So you see the starting point for how we're going to advance the primary care doc's ability to treat obesity starts with a process of addressing what is called internalized weight bias. So the short answer would be asking a patient, once you have asked permission to talk about their weight and that they have said yes, once you have done that, the next stage is to ask a patient about their experience with obesity. So we talk in motivational interviewing about 4 steps. We talk about first asking, and then this active next step, which is called listening. I have my high-tech slides here. This is motivational interviewing. Then summarizing. So what you're telling me is that this has been your story and this has been your experience. And then you'll see the final part of motivational interviewing here is inform and invite. And so that's where, if you want to know where the beginning of our advancement at the primary care level is, that's when the doctor leans in and says, would you consider informing? I'm informing and inviting right now, by the way. Would you consider that what you struggle with is a real condition, that your past struggles with weight have not been because of a flaw in character or a lack of willpower, or you just not being strong enough, or not finding the right diet, or not working out enough. Would you consider that instead your struggle is against a real condition and you've been struggling untreated? There are neurological central elements to this condition, genetically conferred elements to this condition. If you're interested, I would be happy to tell you why I believe this. I can tell you about what are called the neurohormonal elements about obesity, how your brain defends against weight loss. I can talk to you about how the appetite system in this environment drives us to take in more than you need. So I want you to know, and I know it might be a somersault or a different way of thinking, but I'd like you to know that I respectfully understand that you're struggling with a real condition. And I would be interested to hear if you're interested in learning more about why I believe that and how this is a treatable condition, how effective ethical treatment exists, and I might be able to help you going forward. So that's the beginning, countering internalized weight bias in the patient who's sitting across from you, and helping them understand that their struggle is real by starting by telling them that you understand that their struggle is real.
Okay. Sandra.
I don't think we have any more hands up, so I'm going to ask Rachel to give us our first chat box question.
Great. Yeah, we have many questions in the chat box. I'll start with the first one that I saw, which was from Diane. And maybe this is actually a good time now to raise this question. And her question was, does the medication have to continue forever? And is it possible to discontinue the medication? And what happens when that is the case?
Okay, well, that's a great question. And I don't think I've ever given a talk anywhere to anybody without that question coming up, because everybody somehow believes that if I just treat obesity for a short term and help people start on the weight loss journey, I can stop the medication and somehow this is magically going to continue. I know that that is what a lot of people think. That is what a lot of people believe. And I'm sure, Sandy, you've heard this question. Every single talk you give on obesity, somebody's going to ask this question, right? So what's your response?
Time and time again. Yeah, right. So the thing is, a lot of patients come in asking to essentially kickstart the weight loss. I think that's what you're alluding to, right, Arya? We got to kickstart the weight loss. And that's been cultivated in our culture over several, maybe hundreds of years, who knows. But there's no such thing as kickstarting weight loss. We know that obesity as a chronic complex medical condition will need to be treated long-term, similar to diabetes, metformin for a transient period of time and hope that their sugar stays stable forever. My explanation to patients is that we never consider anything permanent. I will never say that you're going to be on this medication permanently, but I do want you to consider that we're treating a chronic condition. Therefore, we have to consider that this medication may be used long-term. And the thing is, I never say it's permanent because we don't know if that patient's going to be a responder to the medication. There's individual responses to the various medications. By about 3 to 4 months, should the patient not achieve a significant weight loss of about 5%, then we consider them a non-responder. And we would consider taking them off of the medication. And that's what I generally explain to patients when they're initiating, is that by 3 to 4 months, we're going to check in again. And if they don't, something else.
So let me turn to you, David, in this question, because I think it's a really important question. Now, one of the concerns that you often hear, and as probably the reason why this question gets asked so much, is because there is this concern about long-term use of medication for obesity. And I think there's two concerns. One concern is about, well, this is just a cop-out and it's just a crutch that you're using, and really it's because you're not doing the work. That's one aspect. So yes, I'll get you started, but then you're on your own. And the other one is this belief that, it can't be good for you. Being on a long-term medication simply cannot be good for you, and that's why we shouldn't even consider long-term use. So these are two aspects, and maybe you want to take the second aspect. I mean, what do we know about the long-term safety and efficacy of obesity medications? And I'm talking about the medications we have now.
Sure. Yeah, I mean, I'll start with a chronic disease that I have. When I was 8 years old, I was at the ophthalmologist's, and he told me I couldn't read the letters well enough, and he kind of leaned in and he said, "You have something called myopia, and you're going to need glasses." And what didn't happen is my mom didn't lean in and say, "Oh, how long is he going to need those for? When are his eyes going to get better?" Right? Everyone understands that it's a chronic condition, and I'm going to actually be, even till today, still wearing these glasses. And so we communicate these principles. Remember, I leaned in to Stephen's question and advised patients, advised him and everyone listening that our first step is to communicate this as a long-term chronic condition. The question you had is, for treatment with medication, what is the evidence that we have around safety? I like to say that we are now, thankfully, entering into a different stage, what I would call a maturity stage in medication. Arya, you would know yourself that 20 plus years ago, we were just entering into that stage with other disease states like hypertension. Treatments, you know, they used to, for treatment for, correct me if I'm wrong, for hypertension, they used to cut out part of your adrenal gland, right? Or they would use some types of different poisons, and people are passing out in the streets. And so this is natural that there'll be a progression of safety as a medication, in this case, anti-obesity medications, mature. And so I'm thankful and happy to say that we are now, in my opinion, entering into what is called the maturity stage in anti-obesity medications, where we have medications that are both effective and safe. Specifically, without naming any names, I sleep much better when I know that we're finally entering into a point where I'm able to suggest to a patient that there is very strong cardiovascular safety data on this medication that I would be providing you. And so that helps me sleep at night. In fact, there might even be, I would say, a chance that this medication might even reduce your risk of heart disease and stroke in the future, exclusive of its effect on weight loss. So that's a comfortable state to be in. I also love talking about cancer risks, because patients will ask, are there any cancer risks? Not only am I able to say that over these many years, the medications we now have available are known to not have any cancer risks, but when we're advising a patient regarding any treatment, in the case of medication, what about the other side? So does everyone you're speaking to know that there is a list of at least 11 cancers that are a result of excess adiposity? From postmenopausal breast cancer to colon cancer to liver cancer to throat cancer to stomach cancer to prostate cancer to renal cell cancer. So in other words, I can, because of surgery data, I can, because of the weight loss effects and cohorts that have been followed long enough, I can actually confidently say that if this medication helps you lose 15, 16, 17% of your body weight and helps you keep it off, look at this data, I have every reason to believe that by being on this medication, you're going to be dramatically reducing your risk of experiencing cancer in the following years that are coming up. And so that's always a conversation I love to have. And by the way, when I have these conversations, I do take some time, because I understand the stigma that is around weight management and around weight management medications. So I really do like to take my time and explain the safety and the science behind the safety data that makes me comfortable prescribing this medication long term.
Okay, so we've come to almost to the end of our time. So unfortunately, we're not going to have time to answer all of the questions in the chat. I just want to remind you again, there is our online community called OC Connect Pro, and you're welcome to join it. It doesn't cost you anything. You can join it through the Obesity Canada website. And if you had questions that you think you would like to discuss with colleagues, you can take some of those questions and perhaps address them there. And I'm sure that our experts here, both David and Sandy, will be able to answer some of your questions on that platform. So having said that, I'd like to thank everybody. Maybe, Preeti, if you can have the poll question that we had right at the beginning, if you can have that back up and see what the results were before we started the conversation. Yes, and we started actually on a positive note, in the sense that 51% of you thought that obesity is a disease of the brain. The other 50% were pretty much equally divided between no, maybe, not sure. Hopefully, you will have, by now have a better understanding why we propose this topic and why we would even consider that the brain is very much involved in obesity in terms of both its etiology, We've talked about all of the genetic factors that are in the brain. We've talked about the homeostatic system, and we've talked about the fact that the most effective obesity medications that we currently have actually all work by working on the brain and changing the underlying biology. So on that note, I'd like to thank you all again for joining us here in this discussion.
And I have a few closing remarks as well before you let everyone go.
No, I'm not letting anybody go yet. I would like to obviously thank, Sandy and David for attending this session. Anyone who wants to find out more about Obesity Canada, you can go to our website, and I'm going to give this back to Sandra now for some closing remarks and some housekeeping.
Wonderful, thank you. Before we close today's session, I want to invite you to consider what you're going to do differently tomorrow morning in your own practice. Will you consider asking permission to discuss a patient's weight? Will you consider using motivational interview techniques and invite your patients to consider that they are dealing with a real medical condition and that you understand that this struggle is real? Or will you start to introduce the 3 pillars of weight management? The first pillar being behavioral modification, the second one being plus or minus medication, and the third one being plus or minus surgery, because this series is about what you're going to do differently. So in the chat box, you're going to find a link to the clinical practice guidelines for obesity. And as Dr. Sharma mentioned, we've run out of time today, but if you want to continue the conversation, please join us at Obesity Canada Connect Pro, and you'll find a link to that in the chat box. And lastly, you're going to receive a feedback form in email after today's session. So please take a few moments to let us know how best to serve you in the future. And remember, if you want to receive a certificate of attendance, you'll need to put in your full name in the chat box. And after attending 4, you will receive that certificate. And please join us again Thursday, September 24th at 1 p.m. Eastern Standard Time, where we will hear from Dr. Stephen Gazer and Dr. Laura Reardon on behavioral medications and surgery, which is right for my patient. So we'll see you next week. Thanks for coming in.